Good morning, everyone. Welcome to the Empowering Nurse Educators virtual series, education sessions. Today's our last session, October 29th. We welcome you to it. My name is Sally Williams. I'm the Workforce Center Director here at the Dallas-Fort Worth Hospital Council Foundation. We appreciate you all joining us today. Hopefully you all can see my screen here. Just double check. Yep. So we'll get started here. First off, I'd like to thank our event planning committee. You'll see the members of that committee here. They were great help in putting together these sessions for us. The next slide here gives you information about our event. If you've got other questions, this website will be where you can go and secure your CE evaluation after we complete the sessions. It will be open until November the 13th, and then after that we will send your certificate for your CNE to you via email. So be sure you get on that website, go to that website for this event, and you will find all the information on the evaluation. We also will be posting the session recordings and presentations a few days after the session, so hopefully by Monday you will see the presentations posted on that website as well. The other two sessions are on there as well. There are no conflicts of interest with our presentations today. And lastly here, questions. We will have a question part after each of our panels. We've got two panels that will be speaking today. After each one, you will be able to ask questions. But we ask that if you have questions as we go along, please post them in the question box on your dashboard. And it looks like the gray button there where we've got there at the bottom of this particular slide. So please post those as we go along, and then we will address them at the end of each panel. So our moderator for today's session is Dr. Virginia Chanley. Brief introduction here. She's a manager of clinical experience at JPS. Virginia leads a team of coordinators and instructors that oversee all student programs, including nursing, allied health, medical students, and research within JPS that require clinical rotations for the completion of their degree. This also includes collaboration with community and academic partners. She has a background in pediatric oncology, pediatric instruction, and a school nurse. Virginia has more than 30 years of educational and provider experience in healthcare, with the last 9 years in her present role at JPS in Fort Worth. Virginia received her BSN from St. Mary's College in South Bend, Indiana, her MSN in pediatric primary care from Seton Hall University in East Orange, New Jersey, and just completed her doctorate in nursing research at UTMB in Galveston, successfully defending her dissertation research on adolescent and young adult advocacy and informed consent on October 1st, so brand new. Congratulations, Dr. Chanley. I'll turn it over to you now for getting us started.
Thank you, Sally. Thank you for that kind introduction. Welcome, everyone. Today, we will be telling the story of the COVID pandemic in the hospitals with a patient care perspective for both nursing students and hospital nurses working in COVID units. What is it like to be on these units? How has the pandemic affected educators in clinical and academic settings, new graduates, preceptors, and students? How is everyone taking care of themselves? Our first panel of 3 presenters will discuss how we take care of our nurses and students during this pandemic. If you have any questions for our speakers, please feel free to enter those questions at any time during their presentations, and we will address all questions at the end of the 3 presentations. Our first panel member is Dr. Glenda Mutenda, who serves as the Director of Interprofessional Wellbeing at JPS Health Network. Dr. Mutenda received 2 Bachelor of Arts degrees from the University of Iowa in Psychology and African American Studies in 2011, a Master's of Arts in Marriage and Family Therapy in 2014 from the University of Houston, and she holds a doctoral degree in Medical Family Therapy from East Carolina University. She completed advanced fellowship training in behavioral health, immersed in medical residency training programs. Her current position at JPS allows her direct access to the residents, oversight of all well-being initiatives, and she holds an integral position in the organization's overarching Caring for the Caregiver Task Force. Her research interests includes well-being of learners, diversity and health equity, and integration of behavioral medicine in healthcare. Dr. Mutenda.
Thank you so much for that very, very warm welcome, Virginia. I really appreciate that. I'm so excited to be joining you all today and talking with you about well-being. And I really wanted to encapsulate this in the midst of a global pandemic, right? There's a context there that's different for our well-being than it was before we were hit with the pandemic. Next slide, please. And since, you know, Dr. Chanley gave me such a wonderful welcome, I don't need to introduce myself too much further, but my email is there. If you want to contact me, please feel free. I'm always happy to talk with members of our community and expand our well-being initiatives and task force. Next slide, please. And so what I'm really going to be talking about today is just the challenges of well-being that we've been facing, talk a little bit about the model for assessing caregivers' needs that we developed here as part of that Caring for the Caregiver Task Force, and then explore the specific tools and initiatives that we've developed and expanded over the last few months. And really more than anything, what I want for you all to get is that I talk in general, but here at JPS, we are an organization of 7,200 employees, and a lot of those are nurses, and a lot of our participation in our well-being initiatives is from nurses and nurse educators and our learners in the building. So I want to put it in that context as well. Next slide, please. And so let me just talk a little bit about some of the challenges that we were facing. So before COVID, we knew that there was already mass burnout in our healthcare institutions with our nurses and physicians and really all of the above. And so we were already in a crisis point that needed a lot of work to try to reverse and improve. We knew that a lot of our healthcare providers, especially nurses with the demands of their roles, were struggling with mental health complaints, and we had poor satisfaction and retention rates in hospitals, you know, in general. And so this pandemic, all it did really was amplify some of the issues that we already had, and in a lot of ways made it a lot worse. So in this pandemic, we're seeing just a lot of people facing uncertainty, the anxiety of that, increased burnout, and definitely increased mental health complaints. And I'll just share some of the recent data on mental health in the country as a whole. And again, what I want to amplify is that nurses are not an exception to these rules, right? What we're seeing in the last few months is that more than 65,000 more people are experiencing anxiety, and more than 100,000 more people are experiencing moderate to severe depression. What we also know is that 1 in 10 Americans has considered suicide in the last few months. So this is very different from before. And what we were seeing in our healthcare providers, in our nurses, I remember those early stories from Italy when we were watching just in shock and awe of how the pandemic hit their country, was that we saw nurses dying by suicide. And of course, here in the United States, we started to hear similar stories of nurses and physicians dying by suicide. So really the context of this is that we were in a crisis, and then this just made it that much worse. Next slide, please. And so with that, what we had done before the pandemic is create the Caring for the Caregiver team. And so I don't exist alone. I am housed in academic affairs, but I have partners all around the hospital system. So the team consists of myself and academics, our executive director of spiritual care and ethics, Leanne Franklin, our director of the employee assistance program, which is our counseling, internal counseling service, Jeff Christie, and our executive director of psychiatric nursing, Shannon Sims. And between the four of us, we really worked hard to assess the needs of the organization in terms of psychological, emotional, spiritual needs, and really have other collaborators like folks in our HR department and so forth to implement new initiatives or expand on what was already available, so that we're constantly reinventing to fit the needs of our organization. Next slide, please. And so in the last few months, we came up with something that was meaningful to showcase how we were looking at the pandemic. And so we created this assessment process or assessment tool, and it's a lot more detailed from what you see on the slides there, but it's really looking at this from three perspectives: the disorientation phase, which is that short-term immediate needs; the orientation phase, which is intermediate needs that sort of are helping us kind of when we feel comfortable, when we're starting to get used to things; and then the reorientation phase, when we're getting reacquainted with whatever our lives are going to be like after this pandemic. And the great thing about this assessment tool is it really goes back and forth, that it's not completely linear. So, you know, I remember back in March, all of us were in the disorientation phase, that short-term, high adrenaline state where we're all trying to figure out what on earth is going on, how we change our systems and processes to fit the needs of our organization, and all of that stuff. And then I remember probably around June, at least from JPS standards, and what I was hearing from our nurses and physicians was starting to get oriented, that we kind of got used to where things were going. And then we went kind of backwards when we got hit with that second phase. So we went back to the disorientation phase. And so I just want to illustrate that these can go backwards and forwards and all around. But as long as we have this framework in mind, we're able to assess the needs of the organization and create initiatives that fit what we're seeing with people. And then the other piece of it is that there's different departments who are going to experience, or who are going to be at different places at the same time. So, you know, our ICU nurses, our critical care nurses, probably were in that disorientation phase much longer than our nurses in our community health clinic, for example. And so different people can be at different places, but as long as we have a way to assess that, we're better able to meet their needs. Next slide, please. And so I'll just go over some of the things that we created in that process over the last few months. We recognized that in that disorientation phase, people were really looking for things to ground themselves, things to give them a sense of hope and normalcy and grounding. And so we created the Mindful Minute, and this was a phone line, and it still exists to this moment. In fact, I recorded a message just this Monday where between myself, our director of EAP, and our executive director of spiritual care and ethics would give a 1-minute message to bring hope, to encourage people to normalize what they're feeling and experiencing, and just to give some people a moment of mindfulness, right? So we had a lot of people calling in every morning, or calling in as a team, as a way for them to start their day with that message of hope and normalization. And then the executive director of spiritual care and ethics created the daily prayer gathering. And it was similar, that people could call in, those who have whatever faith background, didn't really matter. What they've done was create a space for spirituality in general, and it was not related to any particular denomination, but that happened every day, twice a day, for several months. And then we just increased our rounding. So initially, what we saw in March, obviously we all, or a lot of us, transitioned to working from home. And for those who were still working within the organization, it really created a separation and a stressful situation for both of those different groups for different reasons. And so as we were looking at how to safely bring people back, we really made a deliberate decision to increase rounding. So at least once a week I round, I go and I see the residents who are here, who have been here every single day, without any changes or any breaks. So just going and checking in with them, and others in our organizations have done the same. We're seeing our senior leadership doing more rounding as well, to showcase our presence and our support for the people who have continued to do such great work in our organization. And one of just the moments of joy that we had was creating the resident snack shack. So we have approximately 245-ish residents who work at JPS. And just again, when we're in that disorientation phase, we really have to think about the basic needs. Are those needs getting met? And we just created a space where they could get some snacks, they could get some rejuvenation from food, and then go back to their daily lives. And we saw how much joy that brought, and to some degrees that initiative has expanded to other folks. There was also a hope tree, again, really wanting to amplify the hope of the organization, the hopes of our nurses, and our nurses took a great part in a hope tree. And what they would do is write a little message and hang it on this hope tree. And we would see pictures of this hope tree floating around the organization, and different nursing groups would have it. One of the greatest initiatives that I was part of was the EMD therapy. For those of you who don't know what EMD is, it's a trauma-informed therapy model, and we were able to work with 200 therapists from the local area and from around the country to provide our employees with 3 free sessions of this brief EMD therapy to just help them get that stress from their nervous system so that they can continue functioning and providing the great care that they'd been providing all along. And so we were so privileged to have those services for free here. We had lots of our nurses take advantage of that. I will be super transparent. I took advantage of that, and it just made a world of a difference in my ability to function and in my ability to really bring my best foot forward to the organization. We also created process groups, giving people confidential spaces to talk about what they're thinking and how they're feeling, and what's going on in their lives. What are the things that are distressing, and to provide that group support. And more recently, as we're thinking about reorientation, and probably orientation actually, I just launched a peer support program. And what I'm doing is really training peers, especially nurses, to give each other support. Typically, we know that we gravitate towards people that already know us for support. The research shows that we are more likely to talk to a peer about a struggle that we're having, especially difficult clinical outcomes, before talking to somebody else. And so we really wanted to amplify that by implementing this peer support program that will continue to expand. So we were able to target some of our most affected areas like COVID. And that included our ICUs, our critical care staff, our OB, we have our resident physicians who took part in that, and some of our leadership as well. And then the last thing we did was implement more frequent shorts rounds. And shorts rounds was an initiative that we had been doing at JPS for a couple of years now. And what it is, it's an organization-wide initiative that's open to anybody who has a JPS badge to come, and we implemented this virtually as the pandemic continued, to really, again, increase that compassion amongst each other, share our stories and experiences. And we've focused a lot on the impact of COVID in the last few months, but having more of those. And I can tell you just from this past month, our shorts rounds were heavily attended by nurses. And even before the pandemic, they were heavily attended by nurses. But what we see is that it really gives our caring professionals that ability to just let that guard down and talk about how things are impacting them, and build that resilience and build that moral resilience, especially as we continue to battle something that we are unsure of its trajectory. Next slide, please. And so, after reviewing all of those initiatives, my last point is really about the process, that we're always inventing and reinventing and assessing and evaluating our initiatives, and really working hard to cater them to the needs of the different groups. Do nurses need something different from the physicians? Do they need something different from our respiratory care folks? All of those things are in the works. So this is very much growing and building and reassessing constantly to make sure that we're hitting the mark for our staff here. Next slide, please.
Thank you, Glenda. And remember, if you have any questions for Dr. Matenda, please feel free to use the question box at any time during our presentation. Our next speaker is Elaine Beardsley. Elaine is in the role of Clinical Resilience Specialist at Children's Health Dallas. She is a clinical nurse specialist by training and spent years at Seattle Children's Hospital in the emergency department. She received her BSN, MSN, and Advanced Pediatric Practice certification from the University of Washington, Bothell, and is currently pursuing a PhD in Industrial Organizational Psychology. Her program focus for the Resilience Program is to help stakeholders identify barriers for resilience, while also increasing resilience factors to connect with one's strengths, meanings, and purpose. Elaine.
Thank you so much, Virginia, and congratulations on your PhD. What an accomplishment. And thank you, Dr. Matenda, for such amazing, for an amazing message. Next slide, please. So first off, I really want to give thanks to other members of the RISE team, which I'll explain. And I couldn't really be here today if it were not for Stacy Smith, Jessica Rumelat, and Leslie Leach. Thank you so much to them. Next slide, please. So I work at Children's Health, and I am part of the RISE program. RISE stands for Resilience, Integrated Ethics, Staff Support, and Engagement. And RISE originally was developed in 2016, and what it originally focused on was addressing ethical issues in the care climate and educating on moral distress, but also giving all caregivers a chance to discuss in a safe framework moral distress and change and gain perspective. Through that, There was a volunteer cohort who was educated and engaged in these discussions across the organization. But through that, issues such as caregiver grief, second victim, and burnout were really rising to the forefront. So RISE was expanded in 2019, and I came on staff and started developing a resilience program, and Leslie Leach developed a peer support program. That was in October, November, and then COVID hit. So we needed to take a step back and say, how can we support our team? How can we support caregivers and people who are not at the bedside? How can we support everybody? Next slide, please. So what we developed, we still focused on moral distress, clinical conflict, and caregiver grief, but what we found was that the needs of staff that had never used RISE services really was coming to the forefront. So non-clinical staff, clinical staff, both that were taking care of COVID patients, but clinical staff that maybe were not taking care of COVID patients or were in a high-risk group and now working from home. Or we work with a lot of educators, CNSs, people that were normally every day at the hospital, now are working from home. And that really created some emotional distress because their imperative was to feel like they needed to be on the front lines. So what we did, we created virtual kind of hybrid sessions that were really a place for unburdening. And during that, all the social injustice that has been around for hundreds of years came to the forefront. So stressors on so many levels just kind of hit the world and hit the people at everybody, but at Children's Health, kind of just huge. So what we offered was virtual RISE sessions, which were generally about 10 people or less, maybe sometimes 15, of a place where people could unburden. In addition to that, we offered one-to-one group support or group support following an adverse or an unanticipated traumatic event or a medical error. Also, I developed resilience education, and I call it resilience education, and I'll talk to that in a little bit, but really it's not training. Everybody has resilience factors. So resilience education to help people get in touch with who they are, what they find meaningful, and really start kind of uncovering and reconnecting with themselves. And also we did mindfulness exercises. We worked very closely with stakeholders across the organization to identify and mitigate system barriers to resilience, but also we worked very closely with stakeholders to provide care in every realm possible. So in spiritual support, we worked with them. We collaborated closely with HR and EAP, many different areas to provide support. And then we also presented on town hall that every single person in the organization is capable of support, of providing, of listening to people, of encouraging everyone to tell their story. And then we also do conflict transformation training and then education on all the areas that I spoke about. Next slide, please. So our guiding principles. Our guiding principles really within a resilience framework with ethical also kind of constructs is that there's so much opportunity for compassion, satisfaction in healthcare. But there are so many stressors, both within an organizational system construct and now with COVID outside of that. So all of these stressors and barriers can just be cumulative and weigh on the hearts and the minds of our helpers. We are human. If we are to be our best and to give the best care, to do the best role, to be the best team member, in order to do that, we need to honor. We need to honor who we are. We need to acknowledge when we are having stress, and we also need to continually connect with what makes us who we are, and that's our gifts, our strengths, and how we make a difference. So our guiding principles are through a trauma-informed framework, and what we really focus on is creating psychologically safe and confidential environments. And this is either virtual or in person. And the goal of that is so people feel comfortable to promote telling their story. We really believe in reflective insights. When people are safe, feel safe and comfortable, you can start telling your story. And right now with COVID and everybody going through something, the amount of storytelling and unburdening has been minimized. So the perception of loneliness, either perception or real, isolation has magnified. And then that processing of stress and emotion is not happening. So what we really promote is tell your story. What's on your heart? What's on your mind? And what's amazing is when people start doing that, they either start connecting to insights, or others in the call or in person also start doing that. And then you can see either the meaning making or social support happening right in that moment. We also really believe in holding space for both difficult and positive, and that there's place for both. We don't shy away from people raising the difficult, because it's through raising the difficult that you connect to your insights. And then facilitate perspective taking and maybe looking at things a little differently. Throughout this, fostering connection to strength. At the end of each of our calls, we do a strength-based exercise where we just repeat what the strengths have been used, both while processing the difficult and also the positive aspects. And then encourage activities to replenish. We are all exuding an enormous amount of emotional, physical, cognitive energy. So we encourage activities and talk about activities to replenish that. Even activities that if you can't physically do something, that you can imagine, you can savor, or you can look forward to something. So we can encourage that neuroendocrine response. And then first and foremost, we encourage that we all are resilient. We all have resilience factors. We all have strengths, and we all have value. And when we approach it from that standpoint, it just normalizes that, yes, we all have difficulties, and it's okay to talk about them. Next slide, please. So this is a reflection of those hybrid sessions that I was speaking about in our one-to-one support. So from January, and this is very also similar to what Dr. Matinda said, is initially, it started high in January where we were getting requests for RISE sessions, and the graph is representing how many people actually have been involved. But in terms of the hybrid sessions that we've done 170 to date from the start of COVID, and the majority of those they have been dispersed throughout every group, both at working from remote home, in COVID units, critical care units, but also ambulatory. Everybody has been affected in some way. So the trajectory is very resonant of what the literature is now saying. And where there was kind of shock, and then that was really distressful, and then there was kind of a normalization period, but then it didn't end. And then all the cumulative stressors from school, the political climate, economic climate, it's just continuing to raise. And what we're starting to see is also resonant of the literature of kind of some hopelessness and helplessness. So the requests, and I didn't show October, October is way surpassing this. And already we have numerous events and sessions planned for November. People are struggling. People are emotionally exhausted. Absolutely, there's connection to gifts and new, to new skills, to things that we're grateful for. But also there is a lot of distress. So what now we're focusing in RISE is how do we really, in kind of a trauma and disaster trajectory, how do we really encourage people both to connect to their self-awareness, to see where they are, and then to speak up and to reach for help. And we are regularly encouraging EAP assistance. We are not, RISE is not therapy. We are a safe place to unburden. So we absolutely are encouraging additional support. Next slide, please. So in the resilience education that I'm doing and with our hybrid sessions, we really promote unburdening and encouraging others just to tell their story to somebody who can listen and not fix. Just be mindfully present to listen to somebody's story. And another guiding principle, which I didn't mention, which is core, is self-compassion. There's a difference between unburdening and kind of using guilt and shame. That is not going to develop insights. It's going to almost worsen kind of our self-perspection of ourselves. But with self-compassion, if we acknowledge that we have value and that it's okay that we are expressing our difficulty, but we do it with loving kindness, we are more likely to come up with insights. And we consider other perspectives. We develop ways and encourage ways of people to really foster that connection with others. And then discuss ways and new ways that we can replenish energies. We may not be able to travel or do things like we used to, but what can we do differently? Where do you find joy? Definitely, we have to encourage people to acknowledge your limits and boundaries and support healthy habits. And then again, normalize it's okay to have difficult times and talk about it. Next slide, please. So as I close, I just want to do 2 slides of kind of an example of what we do in both the hybrid sessions and the resilience education. So first, just sit in a comfortable position and take a slow, deep breath in through your nose. Just expand your belly outward and then slowly breathe out. And now just ask yourself, just remember, go back. Why did you go into the profession that you're in? Why did you go into the role that you're in? What was it that attracted you? And what gifts in yourself did you see that were exactly fit for the role that you're in? And now think about a time that you used those gifts. Think about a time in the last few weeks where you used those gifts that just make you feel energized, where you know you made a difference. And then I'll either go on and do mindfulness around this. I'll ask people if they're comfortable to share, or to do a reflective or a narrative reflective activity where they write or tell a story. I love storytelling, and ask people to tell a story in a group dynamic. Next slide, please. And then I'll also ask, okay, think of a time where you felt like you were not making a difference or felt depleted. And sometimes people will say, well, yesterday, today. And then just allow them to get into themselves. What we absolutely have seen is that stress almost promotes a disconnection of self. So it's actually even hard to do a self-awareness check, to see where you are, to see where your stress loads are. And we know through literature that stress can elevate, and we don't even know where we're at. And actually, because of the sympathetic overload, we're not used to checking in, and we might even have kind of a negative attribution bias of where things are on. So asking, where are you at? And what are you feeling? And even though it is very difficult, to start kind of talking through it, like what are some takeaways, and what are some takeaways of your experience of what you're going through, and are there any ways that maybe you have done something that you're not even realizing that you did. So the strengths, and then we continue to encourage people to tell stories. What actually we find is that meaning making occurs, and that if somebody can tell their story, and the meaning making may not be big, it's not meant to fix, it's just allowing people to develop insight. But once through that self-compassion and safe space and almost connection to who they are, the strengths and the meaning come through. Next slide, please. So in closing, just overall in some kind of what we're doing through RISE to support people is really promoting people to tell their story. And that can either be one-on-one, in group, or we're giving education on active listening and to support really connecting to people. Support giving meaningful gratitude. Right now, the literature is showing that people who are directly involved with COVID actually are connecting to their meaning and purpose. But so many healthcare workers and professionals are not directly involved with COVID, and actually their connection to personal achievement is dropping, which just adds to the emotional labor and emotional exhaustion. So give meaningful feedback, give gratitude, and also connect in yourself where you're at, and also what your strengths are and how you're using those strengths. And then talk about it. Talk about where you're at. Find someone to listen. Find somebody to just embrace your story. Thank you so much.
Thank you so much, Elaine. Our next presenter is Dr. Lynn Prater, who is currently a clinical professor at Baylor University, Louise Harrington School of Nursing, where she teaches primarily in the undergraduate program and is the coordinator for the 4th semester graduating senior students. Her research interests focus on maternal and child health, as well as building nurse capacity internationally. In 2016, she was appointed by the provost to serve on the University Quality Enhancement Plan Steering Committee, focusing on global engagement. In 2019, she was named Baylor Fellow from the Academy of Teaching and Learning, with the emphasis on education for global engagement, and in 2020 was named Senior Baylor Fellow for Teaching and Learning with Technology. Her passion for international work began in 1977 when she was faculty sponsor for the School of Nursing Heritage Medical Mission trip to Mexico, which continued for 25 years until violence along the Mexican-American border made it unsafe for student travel. Since that time, Dr. Prater has initiated and participated in many collaborative efforts with faculty and students on mission trips, international delegations, and study abroad programs in Argentina, Great Britain, India, Iraq, Mexico, and Vietnam. Dr. Prater.
Well, thank you. Thank you so much, Virginia. And thank you to Glenda and Elaine for those two great presentations. So interesting and important to hear those words. You can change the slide, please. So today I want to just share with you a little bit about the story of how we at Baylor School of Nursing are helping our students during this pandemic time. As I said, or as you said, I look after all the second semester senior students at the School of Nursing, and they're the faculty and the students in that cohort. So as you all know, last spring we had the beginning of the pandemic, and at spring break, our university decided to give the faculty and students an extended spring break of 1 week to prepare for teaching only online for the rest of the semester. So we worked for a week and got our teams together and set out to put our clinical modules online and all of our classes online. So for that cohort, we only had 2 weeks left in the course that I teach, the Senior 2 capstone course. But unfortunately, our students were not able to participate in graduation ceremonies. The university did not have graduation. We did provide a drive-by pinning ceremony, so students could come by the school at appointed times and pick up their school pin. But I think it was, a great disappointment for those graduating students. However, we were all sort of in that disorientation mode that Glenda, you spoke about earlier. We were just trying to figure out what was going on and what was the best way to get our students finished during the semester. Next slide, please. So during the summer, we had time to plan for fall and what that might look like for both our students in the classroom settings and in clinical. Next slide, please. The first thing that we decided was that our students would not be allowed to take care of COVID patients. We were so hoping that our practice partners would allow our students to come back to the hospital to care for patients, which they did. And I want to say a huge thank you to all of you out there who help us in your nursing student role to allow us to come into your hospitals, because we obviously could not do the work we need to do to get our students ready without being in your places of work. So the other things that we did to help our students get ready were we had a random before we even came back to school, we tested all of our faculty and students for COVID before the 1 week before we started. We gave our students the choice of either coming to class in the seat or coming in online. We gave each student two face masks and 1 face shield, and we fit tested all of our students within 95 masks. And we ensured that our students knew what policies and procedures were in place once they came back to school for exposures and quarantine and that kind of thing. Next slide, please. So our simulation team did just an outstanding job of being able to get our supplies ordered during the summer so that when we came back in August, we were able to come to the sim lab and get everyone fit tested. So, we have 425 undergraduate students that needed to be tested. So it was no small tasks. Next slide, please. So these are just some pictures of our students in their kit getting ready to go to clinical. We also, all of our students rotate through the simulation lab for part of their clinical time. And we require our students to wear the full kit while they're taking care of the simulated patients as well, so that we can help them be ready and understand what the normal now will be as we go to the hospital. Next slide, please. We know that all of the different hospitals and practice partners had individual requirements that we had to meet. And we have a person in our department that is our point person for the liaison, and she was able to make sure that we had all that information that we needed. We also had to ensure that modules, equipment, and documents were in order for our practice partners. And again, how grateful we are that you are all able to host our students. Our students are back in all of the same facilities that they've always been in, and are having wonderful clinical experiences there. Next slide, please. So as I was preparing for this talk, I knew personally, of course, what our school and university were doing to help support our students. But I wanted to hear the student voices. So I drafted 5 questions, and I met with the second semester junior cohort and asked the questions, and then I went to my senior 2 students and asked those same questions. So here I want to share with you now what the students are saying about how they're feeling supported during this time. So the first question I asked was, what concerns did you have before starting the semester, both class and clinical? The junior students said that they were worried that they would be at greater risk for COVID, but because they received masks, shields, and N95s, this was 4 weeks into the semester I asked these questions. Because they received all their materials, they felt fine about it. Both juniors and seniors said that they were worried that they would have limited time with patients because we had to leave early in the spring. They were very worried that they wouldn't get the patient care that they wanted, the patient contact. But because we're able to go to the hospitals, that, again, worry was allayed. And the seniors were worried that they would not be able to graduate on time, that they wouldn't have as wide a variety of patients to care for, to learn as they were getting ready to graduate, and that they were worried that clinical would be canceled and that they would only have virtual simulations. Thank goodness that has not happened. We continue to be in clinical for all of our level of students. The second question I posed was there anything, next slide, was there anything we could have done to help decrease your anxiety before the semester started? Our juniors said nothing. Our seniors said that the daily updates were helpful. Now, our university president from Baylor University sent out a weekly update all summer and starting in this fall, and many times several updates during the week to keep everyone informed about what was happening at the university. And then our undergraduate program director also sent out weekly updates about the School of Nursing. And so we had great communication just all along the way, which I think was so important to our students. Other students said talking with student services director about the school's desire to continue with clinical. We see this theme of the students fearing that they would not be able to go to clinical, and thank goodness, again, that was not realized. One student said there seemed to be many changes up until the start date, but COVID was changing, so not much could be done. You know, one day we would hear one set of information, and then 2 or 3 days later we would get some different information from the university about policies and procedures, which again fell right in line with how much change this COVID was causing just in all aspects of our life. Next slide, please. The third question I asked was, what issues have arisen during clinical that have caused concern? Our junior student said nothing. Clinical has been the most stable thing this semester. Now, I will say that our junior level 2, the junior 2 students and faculty the faculty chose to teach those courses all online, the didactic courses, whereas some of the other levels chose to have their classes in the seat. And so I think this answer comes because this cohort of junior students are taking all their classes online. So they were thankful to be able to go to clinical and be caring for patients with their instructors present. The seniors answered this question by saying some confusion. There was some confusion regarding taking care of patients who were persons under investigation on the unit, wearing kits for them or not. Some patients were testing positive but were still deemed non-infectious. So just some of those issues that we all deal with in the hospital. I still practice once a week in the hospital as a nurse, so I understand some of those conflicting kinds of things. The other student said not having an N95 mask that fits. So I told you that we fit tested all of our students at the beginning of the semester, but we were not able to get small size masks in that first week that we fit tested students. And it took a couple of weeks for us to get the small sizes in. We've since been able to get everyone fit tested for the 95 in their correct size. Next slide, please. The fourth question I posed was, do you feel you have been supported during clinical regarding this COVID time, and how? Our junior said yes, the stability of the instructors being encouraging and protective. Again, we say our students are not allowed to take care of COVID positive patients. And so I think the faculty being on the front line with the student in the hospital setting, helping them navigate those units, because we know in some of the places we go, one patient on the unit may be COVID positive and 2 doors down, they wouldn't be. And so just having our faculty and the staff nurses help our students maintain that safe zone. Faculty were more concerned in the person than in the objectives. And so I think that again just shows that this semester we are just trying to show grace to our students regarding what they may be dealing with at home. Some of our students live with elderly parents or grandparents and are concerned about that. But all students have been participating in clinical unless they've had to be quarantined. And then the last on this page says faculty were advocates for students. And I'm so proud of our faculty for being that advocate. I think they are, we're so concerned that we keep our students safe. Next slide. These are continued answers to this same question. Senior said yes, preceptors have been protective, making sure students were not with COVID patients. Strong communication on the units with managers was helpful to students. And another student said, yes, I'm always provided with the appropriate PPE. Next slide. Senior said random testing at LHSON. So since the semester began, every week we are doing random testing for a percentage of our students and our faculty as a part of our surveillance and monitoring program at Baylor. One student said running interference by the preceptors on our behalf was helpful, and the contract that they signed that they would not take care of a COVID patient helped them feel safer. So again, I think just that whole, what we're hearing is the protection that faculty and nursing staff on the units have provided our students has really made a big difference in how they felt. Next slide, please. The fifth question I asked was, what do you need from your instructors, school, or university that you have not gotten? What would make you feel more supported? Our junior students said some wished that their classes were in person and wanted school to provide tutors. So we do have a student services department that works with students who need extra help, and they do have instituted some tutoring sessions now because of these students' requests. Our students said nothing to this answer, so I guess they feel like they're getting what they need, which is very good to hear. Next slide, please. Then I have some anecdotal notes to share with you from both faculty and staff at the school. Because we all work as one big team, our faculty and our student services department, our chaplain, our secretaries, we all work together as a team to try to support our students, not just through the COVID time, but especially now, as we've all heard that we're all sort of at a heightened need for extra support. The anecdotal notes that I heard are that most students are coping well. Like I said, we meet with our students weekly. The faculty are at the bedside with their students, so they're able to see that. Some students have expressed loneliness if they're living alone or with roommates that are not present at the time. So because some of our students commute to our school, they may live with their parents in Frisco and commute down to the School of Nursing, or maybe they have an apartment with a roommate, but sometimes that roommate may have moved home. So we have noticed an increase in some students' feeling of isolation during this time. And then there was some confusion if a student thinks they were exposed or what to do or what constitutes an exposure. So we're constantly, asking the student to please, share with us what they're concerned about. If they feel like they've had an exposure, we could talk with them personally and get the story, and then are able to help them navigate whether they should quarantine or whether we don't feel like it was an exposure. So again, just trying to stay connected and keep those communication lines open. Of course, we know are just critical during these times. Next slide, please. A few resources that we have at our School of Nursing for our students and for our faculty and staff, but specifically I'm talking about students, are that we have a contract with the Sparrow House Counseling Center, whereby each of our students can receive 6 free visits to that counseling center. And this has been in place for many years. So it's not just because of COVID, but I think we have more people taking advantage of this opportunity since the COVID pandemic has hit. Like I said, we do have a chaplain on staff at our School of Nursing, housed in the Student Services Department. But we also have 4 or 5 student services personnel that are wonderful counselors for our students and stay connected with them. We have a financial aid counselor on our staff that because of COVID, we've had to he's had many more visits from students and questions, and he's doing his magic to try to help our students that are having financial issues. Then, of course, the faculty of the individual courses provide support for students. As I said, our simulation lab director and team have just done wonders to help get our equipment ready and to continue to provide that equipment and help students through if they need more equipment. Continued updates from our university president and from our School of Nursing dean and associate deans have just been wonderful in keeping us informed of day-to-day kinds of issues that both faculty, staff, and students need to hear. We've even had to provide a hotel for quarantining a student who did live with their elderly parents that was exposed. So we follow the same guidelines that our students in Waco, where our main campus is, that are housed in university housing. If they have an exposure and need to quarantine, they have special places that those students can live. And we've tried to provide that same support at the School of Nursing in Dallas. Even though this student was not living in university housing, we felt like it was our duty to help provide them a hotel room for 2 weeks while they could quarantine since they lived with elderly parents. So that's just one example, I think, of how our School of Nursing has kind of gone above and beyond to try to take care of our students during this time. Next slide, please. I'd like to talk just a few minutes about what we're doing as we prepare for spring, because we see the uptick in cases in the Dallas area on a daily basis. So we don't really know what our spring semester is going to be like, but we're hopeful that we'll be able to continue in the seat classes for those faculty and students who want to be in the seat. and that we'll be able to continue to take our students to the clinical setting and take care of real patients. We'll be continuing our surveillance measures with random testing. And again, I just want to say a big thank you to our practice partners all over the Dallas-Fort Worth Metroplex that host our students, that do go above and beyond in trying to make sure that we have the documents and the equipment that we need to be able to have our students participate and taking care of patients so that they can then graduate and go forth and serve as a nurse, whether it's in the Dallas-Fort Worth area or whether they go back to their home state when they graduate. So next slide, please, and I'll just ask if anyone has any questions from me about how we are supporting our students.
Thanks, Dr. Prater. Sally, do we have any questions for our three panelists?
We had one question. Is the framework available to be used by others? Do you have any literature related to the framework? More details. Thank you. And this came with our first presentation from Glenda.
Yes, this is an open framework, and I can find it and send it so it can go out with the materials afterwards. But we didn't create this framework. We just adopted it from a previously developed one that's really looking at the grief process and how that's applicable to all the things that we're going through right now.
Thanks,
That's
Dr.
the only question so
Okay,
far.
so Sally, we don't have any other questions?
Nope.
Okay, so then we'll move on to our second panel. So our second panel today is going to be discussing what our nurses and students are experiencing during the pandemic. There will be 5 members on this panel who will each answer these 3 questions. How has the pandemic affected your job? How has your workplace been affected by the pandemic? And share your challenges, opportunities, and any lessons learned. Our panel members consist of 2 COVID unit bedside nurses, 1 nurse educator, and a preceptor new graduate dyad from the ED. I will give their introductions first and then let all of them speak, and we will hold questions and answers to the end. So please, at any time during their talks, add any questions you may have for the speakers into the question box. And if you can add also who you're addressing it to, that will help. And we will answer all of your questions following the presentations. So our panel members are as follows. Bianca Castillo is a BSN 2015 graduate of Baylor Louise Harrington School of Nursing and was inducted into the Honor Society of Nursing Sigma Theta Tau Eta Gamma chapter. She completed the 2016 critical care residency at Parkland Hospital for the medical ICU. As an RN, she represented the medical ICU in the Quality and Safety Committee at Parkland, and in June 2020, she volunteered to staff the Tactical Care Unit, or COVID ICU, and in August 2020, she formally transferred to that unit to help the ongoing COVID response. Tracy Wood graduated with her Bachelor's of Science in Nursing from Texas Women's in 2011. Upon graduation, she started working at John Peter Smith Hospital, initially in the trauma step-down unit, and then with our wound care team and ICU. In 2015, Tracy expanded her nursing skill set and worked part-time with pediatric patients at the Texas Scottish Rite for Children in Dallas. In 2017, she moved to Botswana to serve in the Peace Corps. Lessons learned from the Peace Corps include the importance of consistent utilities and making it work. In the fall of 2019, Tracy returned home to JPS and is one of the inpatient diabetes educators for the hospital. Tracy has her CCRN and is currently working towards her CDCES in diabetes education. She enjoys reading, traveling, running water, and air conditioning. Joelle Couture is a BSN clinical educator. Nursing is her second career. She decided on after many years in retail and merchandising management experience. Her husband was a firefighter and paramedic, which piqued her interest in the medical field, so she went back to school. She worked as a nurse in the emergency department at Texas Health Arlington Memorial for 8 years. She started as an ED nurse educator in February 2020. She currently works within the ED work group and shares responsibility for educating all Texas Health Resource hospitals, but specifically is responsible for Texas Health Resources Dallas and Kaufman EDs. Our new graduate is Kaylee Womack, and she is at John Peter Smith Hospital in the emergency department. She was born and raised in Los Angeles, California, and moved to Texas in 2016 to pursue a nursing degree at Texas Christian University. While in nursing school, she worked at JPS as a patient care technician in the neonatal ICU, but found her true passion for emergency nursing during her critical care clinical rotation in school. Upon graduation, she was offered a new graduate position in the ED at JPS, and she could not have been more thrilled. She has been a nurse now for about 10 months and feels so lucky to have been afforded this opportunity. JPS has made the greatest impact on her learning as a new graduate and offered her a chance not only to further advance herself, but make a difference in her community. And Margaret Conder is her preceptor. She started healthcare career by working as a patient care technician at Morningstar Memory Care in Fredericksburg, Texas. After specialized training in dementia, she helped care for patients as a summer intern while completing her nursing prerequisites. While in nursing school, she worked as an emergency room technician and then as a nurse extern at Longview Regional Medical Center in Longview, Texas. She precepted new nurse interns and assisted with their training and lab skills on the unit. After receiving her BSN from the University of Texas in Tyler, she worked at Longview Regional Medical Center in their emergency department. She then moved to Fort Worth and in June 2019 began working in the emergency room at JPS Health Network. Early 2020, she became a preceptor just as the coronavirus pandemic began. And so she's there in the ER currently. There are our 5 panelists. We will go ahead and start with Bianca, followed by Tracy. Bianca?
Hi. Okay, so to answer the first question, the job hasn't necessarily changed, but the pressures and burdens of what's happening has changed me. I come from a 35-bed unit, the medical ICU, where maybe half of the patients were rented. We have a 1-to-2 nurse ratio, 1-to-1 nurse ratio for high acuity patients, or patients that are on CRT, intra-aortic balloon pump, or MPOA. And about 3 to 4 years ago, there was a flu season where we had like 4 prone patients, and we had a rotor-prone bed for those patients and a 1-to-1 nurse ratio. So compare that to now. We now have high acuity patients that we can no longer single just because there's not enough nurses. The other thing that the pandemic has done is because there have been restrictions with families not being able to physically be there for the patients, we sort of kind of we've taken on the burden of being there more emotionally for the patients, especially in the end of life circumstances. Also, the plans have been changing every day with, as you know, COVID cases continue to climb. We were in the PACU over the summer on the 3rd floor, and now we moved into 2 floors, and now we've since added 2 additional floors. So right now we have 4 floors dedicated for COVID patients. So we have to be very flexible. To answer the second question about how the workplace has been affected by the pandemic, is that we went from having enough PPE for everybody to rationing PPE and PPE shortages. We've also had medication shortages, staff shortages, just because everyone is leaving to go travel. And again, the immense of a lot of patients just coming in and kind of overwhelming the hospital. The Parkland has required everyone to be wearing a mask and some sort of eye protective equipment, and we've all implemented social distancing. So that's another thing that's sort of changed the workplace. I get at least 4 temperature checks a day. And there is a COVID questionnaire that we all have to complete prior to coming into work. Some challenges and opportunities. So there has been a language barrier. A lot of the patients that I've taken care of, I don't have the exact percentage, but a lot of the patients I've taken care of have been Hispanic and Spanish speaking. And although we do have the language line available, you know, it's a different story where, you know, patients are struggling to breathe, and you know, intubation is sort of a rapid emergent situation instead of waiting to go and call the language line. So so that's had been an issue. Infection control also, when we were in the PACU, we were all wearing a gown and N95 and a shield and gloves, and it's very much a teamwork environment. So a lot of these patients were getting manually proned. So you have a team of nurses and doctors and RTs kind of going in and helping everybody. And we did have an outbreak of CRAB, carbapenem resistant Acinetobacter baumannii. So I know that was something that was a big issue within our unit, but we have since controlled, since we kind of moved into the more traditional ICU rooms. Some opportunities is, as bad as this virus is, it's a new virus, and it is a good learning opportunity. We've taken nurses from different units, from the burn ICU, neuro ICU, surgical ICU, medicine ICU, and we've converted it into one unit. And in the RTs, the CRNAs, everyone have come together, and it's been very humbling to see everyone sort of come together for this one cause. So the teamwork, the learning experiences, and that's really what's been a good opportunity for COVID on our end.
Thank you, Bianca. Tracy?
Thanks, Virginia. So when the pandemic hit, I am a diabetes educator. I am not full-time at the bedside since I came back. And they did an all-call to see who had worked where. And so I volunteered to go back to ICU because I knew I was going and I wanted to try to be safe. Our ICU is integrated, so we didn't really have a unit dedicated to COVID at first. So people are roaming with COVID patients and regular patients wearing the PAPRs on the floor. We would announce 15 minutes of isolation time when we had to do a transport, which for the record is a lifetime when you haven't touched a patient in 3 years and they're both trying to crash. The patients in general are also a lot sicker because no one wants to come in to the hospital because they're afraid of COVID. With the isolation time, all the doors were closed. We stayed put until the transport was done. And it was like that for a while until we could close down another unit. And set that up as the COVID ICU, which I lovingly call the pit. So the first day I was asked to go in, I cried when they put the PAPR on me, and it wasn't so much because I was afraid of the virus, because it's germs. But I had seen how tired the nurses were that I was relieving, and it was more of a moral dilemma thing, because at that time we didn't really know what we were working with, and no one who went in was coming out. So it was kind of horrible on its best day. We tried a lot of stuff. Some of it worked, a lot of it didn't. And I got to be in there for when we were trying team nursing. So I was the medication nurse, and it was like something out of a movie. There was just a sea of people, and they all looked the same, and they were all intubated, and they were all sedated, and they were all prone, and everything is beeping, and you can't tell where it's coming from, and they're all really important beeps. And so you're kind of just running around trying to put out fires all day, but you're 3 times as big as you would normally be because you have this big spacesuit on. It really highlighted the teamwork that that unit has, and that was pretty amazing. There were patients down there who would be awake down there for a while and able to speak. And there was one in particular who just watched for weeks as we coded people around him over and over and over in our spacesuits. And he asked if he would be okay, and I couldn't answer. So I tried to keep him comfortable. And then when I went into work the next time, he wasn't there. He never came out. During all of this, I was also still doing time in my regular job as a diabetes educator, and slipping back and forth was a very big challenge. We've since streamlined a lot of things, learned a lot of things, got some help from travelers. It's still pretty awful to go in, but it's definitely gotten smoother. How has the workplace changed? You can't just come into work anymore. You gotta use a special entrance, wait in line, answer the questions, get screened. And when it's shift change rush, that can add on forever to your shift. And then if you have to get your new mask for the week, that adds on even more time. Lots of people have been working from home, which is great that we have the ability to do that, but it really takes away from the bond that you get with your coworkers, especially in my non-direct bedside job. The no or limited visitors was a very mixed blessing for me. When I first went back to the ICU, I loved it because nobody was asking me questions every 5 minutes while I tried to get my sea legs again. So I was really thankful for that. But at the same time, when someone's really, really sick, you want a family member at the bedside to really be able to see what's going on. An intubated, paralyzed, sedated patient, they look like they're sleeping on the screen, and it really can be misleading to the full picture. Virtual meetings have been really handy. I like that I can have a meeting from home on my day off and don't have to take a whole lot of time to, get out, get dressed, go through the screening, and then get back home. We've rearranged offices to allow for social distancing, which is really cool because I share an office now with someone I never would have gotten a chance to know. And it's been really neat to get to know new people. On the flip side of that, I never see my counterpart because we stagger days so that we can share a desk. And I miss seeing her and being able to run things by her. So it's just an adventure. How has my job changed? There's a bigger degree of separation because of PPE. You can't see facial expressions of your coworkers and patients. And I think that there's a lot unsaid that gets lost with that. And I just really miss seeing faces. In my regular job as an educator, we try not to come in direct contact with COVID patients because we're all over the hospital, and so that we can try to prevent cross-contamination. We do a lot of phone education with COVID positive patients, which seems really impersonal, even if I'm staring at them through the window. And when someone is in here with COVID, they don't care what I have to say. I'm really low on the list of their priorities. So we work really hard with the bedside nurses to try to get them taken care of and sent home as safely as possible. If we do have to go into a COVID room, we save them till the end of the day. And by then, everybody's just tired. I make people cry a lot more. Bedside is even busier than it used to be. And it's so task oriented now. And so when I go in as an educator, I'm the first person who sat down and talked to them in months sometimes. And it can be really overwhelming for them to have someone just sit and listen. And so I make at least 2 people cry a day just by being there, which is really special and really exhausting all at the same time. We've been a lot busier because diabetes makes people vulnerable, and a lot of people haven't gone to the doctor because they feel fine, and then they're coming in with new diagnoses, which just piles on to all of the other stress that they've been having going on. More people on the phone. I hate talking on the phone. Educating patients, they may not be able to absorb or have the ability. Family members, it's hard for them to understand. It really highlights how we can be really, really connected, but sometimes I have to talk to 6 different family members about the same thing because we still don't really communicate with each other. Challenges and opportunities, I've already touched on a lot of it, but mental health, everybody's stressed, everybody's tired. I use the Hope Tree and the Mindful Minute that Glenda mentioned earlier all the time. They've done a really, really good job, I think, with the horrible situation here at helping to take care of their staff. It's been really hard to be hailed a hero when you're in the hospital, which makes me uncomfortable. But then when you get out of here, you're treated like Typhoid Mary because you're dirty. Support systems. I was great to call back to the COVID ICU because I don't have a family or kids. But at the same time, I go home to an empty house. So that can be hard. The degree of separation that PPE causes, the language barriers, and having to throw all of this through a phone with the translator. I touched on the not having visitors, the moral dilemma in the ICU, and the staffing. For me personally, the flipping back and forth was the hardest part. Because on one side I have to be open and empathetic, and on the other side it's okay, let's make sure this person, we try to keep them alive. I think one of the biggest opportunities is the cross training that's been allowed. We've had a lot of PCU nurses who have been floated to help out, and it's kind of brought the ICU down from the ivory tower. There's always been a big degree of separation and mystery around the ICU. And I think that it's really, really promoted communication and teamwork throughout the hospital. And because in my diabetes job, I get to travel everywhere, it's kind of, people are able to ask questions and kind of just become more comfortable with what's going on. It's given me an opportunity to really bond with the patients that I see in my educator job. They've been a lot more engaged, and even if I'm the only choice they have, I'll take that. And then technology has been amazing. Being able to work from home, have virtual meetings, have families FaceTime with their person, especially if they're out of town or out of country. It's been really, really handy to be able to keep those lines of communication open. Yeah, it's been really hard, but I think that the hospital has done a really good job, and it's really highlighted the amazing staff and teamwork that we have here. And thanks for letting me tell my story. It was actually very therapeutic.
Thanks, Tracy, and thanks, Bianca. Your stories both are truly amazing. Our next panelist will be Joelle Couture, who is an ED educator.
Thank you. I had just gotten my foot in the door as an educator when COVID hit. So the changes have been pretty apparent to me. We have had to, and just to let you know, I work in the ED at Arlington Memorial as an ED nurse, and then I got this job as an educator. So I've been doing both still. As far as the education goes, we've had to increase the planning time to include infectious disease precautions. We also had to make sure that we had all the necessary equipment on hand to take care of those precautions. We had new employee orientation procedures that had to be changed to accommodate these precautions. We moved basic PPE to the bedside and moved restraint checkoffs to the entities. New hire orientation had to be streamlined. We had to learn how to think out of the box, and that was a big part. We converted many trainings to be online, and then we had to figure out how to make those trainings engaging and stimulating. We had to develop and implement emergent trainings for staff members who were moving from different areas, just like what Tracy was talking about. And then our code response changed, so we had to develop trainings on that. So lots of trainings were going on. We went from these large interactive face-to-face trainings, and then we went to no trainings at all, and then we went to online trainings, and now we're back to small, less interactive face-to-face trainings. So that has been a challenge. The staff has been so busy and so tired that we really needed to prioritize our trainings. We didn't want to add any more fluff in there. We had to go with just necessary trainings. Went from officing out of my house, my entity, to officing out of my house. And then I had to deal with overused home internet, VPN, no printer, no supplies, nobody nearby to toss ideas around with. And being a new educator, I really needed that time with my cohorts to kind of toss things around. And then the worst thing was I had to deal with my noisy dogs. Let's see, many of us got put in different jobs as well. So as well as being an educator, I did go to the hospital and work in the ED. I also did COVID hotline, which was super fun. I was a proctor, a greeter, a screener. I am a very well-versed EPIC trainer. And then how has my workplace been affected by the pandemic? I would say that going from an office space at my entity to working out of my house with limited equipment has been probably the biggest change. I'm at corporate today, and it's very scarce in here. There's very few people. Everyone has had to adapt and fill in the gaps wherever we've been lacking. There have been many, many changes, and everyone has had to adapt very quickly. I remember before COVID, when it would take about 6 to 9 months to just get something implemented. Now we have to do it, overnight. We have had some people leave. Most of them have been retirements, so that's been good. As far as opportunities, I would say that we have found out that we're more adaptable than we thought. We've been able to be flexible, and the changes have come so quickly that we've been able to adapt quickly for that too. And that has helped us to be able to continue working, which I appreciate. Challenges, there have been many, many changes. There are many new nurses working who may not have the same hands-on training that other staff has had. And so a challenge as an educator is to make sure that we're providing as much opportunity to enhance their education as possible. Lessons learned, I would say that safety comes first. Just knowing that you're doing the right thing to keep yourself and others safe is a big lesson. I appreciate my team. I realize that this is so big. Whenever I've asked for help, haven't had just one person be willing to step up and help. I've had my whole team do that. And I know all the other nurses have talked about teamwork, but teamwork is a big, big part of, how we're getting through this pandemic. Good communication too, good communication and teamwork. And that's what's gotten us this far. Thank you.
Thank you, Joelle. Our last two panelists are a preceptor GN dyad, and we're going to let Kaylee Womack, our GN, speak first, followed by Margaret Conder, who is her preceptor. Kaylee?
Hey, everybody. Okay, so these questions were a little bit difficult for me to kind of reflect on, only being because I'm a new nurse, so I don't know what the JPS ER was like before COVID started. It was definitely something really exciting, definitely nerve-wracking coming into. Of course, the pandemic made a really big impact on the roles of nurses. I knew that coming into it, and that was something that I did feel very proud of, to be a part of it and really like be on the front line. My mom's a nurse, so she, was super excited for me, very concerned, of course, but it was something that I was just excited to be a part of because it really was such a big deal to me and where I am at in my career. I feel that the way that, when we first started seeing these patients come in and the acuity of how they were, and there was a lot of uncertainties and things that we changed about doing, different safety precautions. A lot of stuff changed. We learned a lot about, best ways to manage the COVID patients. Really was great to see the way that all of the different members of our team came together, whether it be providers, respiratory, pharmacy, nursing, our EMTs, like everybody absolutely came together and had the patient as our top priority. So I felt like, I don't know if it necessarily affected, and it definitely affected the nurse, but at the same time, I feel like nurses always will do anything to better the outcomes of their patients. So tackling the COVID pandemic was no different, with that being everybody's goal. The way that it affected the workplace definitely was interesting, with all the different PPE restrictions. Like we were saying earlier, our hospital also does take a ton of patients who don't speak English at all. A lot of times we had a very short period where we did allow visitors, and to some extent that was helpful when we would have family members that could translate. Little things, of course, we had our language lines all the time, but wearing a mask is definitely something where you can't really read someone's lips or understand how they're feeling with their facial expressions. And then when it came time to working directly with COVID patients and wearing the big PAPR suits for a couple hours at a time, the patient can't really understand what you're saying or hear you very well. And I felt like I was screaming at the patient so they could hear me. But it was definitely something that was very different in the workplace. I felt like as a new grad beginning my career as an ER nurse during the pandemic, trying to learn everything and soak everything up, learn everything Margaret had to teach me, work directly with the providers and all of the different staff. It was definitely a challenge. I remember telling Margaret the first time we had a code on a COVID patient, we were in our spacesuits and the PAPRs, and the rooms that we had to switch over to were slightly smaller than the typical rooms that we use for priority alerts. And so all of us were in there, team nursing, getting it done, but it was definitely added another level of stress of, here I am, I was a white cloud in nursing school, so never had even experienced a code, to now I'm in a code. I feel like a beekeeper astronaut in this huge suit, and just trying to navigate that situation was definitely extra stress. Something that I'm very appreciative and thankful for, however, because I feel like that was the best silver lining to the entire situation, was learning how to not only be flexible but adapt to different situations in order to not only provide the best care for your patients, but for the team to come together and try new things and see how everything works. It was really nice to see everybody just being so willing and able. And especially as everybody's learning new things, the entire team just, I never felt uncomfortable asking, needing to debrief. I always felt like I had so much support. So it was really reassuring because, of course, being a new nurse, I was already very, unsure of the way things were. Clinical setting is definitely a lot different than having your own patients and having, a higher patient load with high acuity. It's definitely something I wasn't necessarily used to, but it's something that we were able to tackle as a team, and just having the support from all of the members, especially Margaret, like it's been amazing. So it's been definitely challenging, but the flexibility of learning how to adapt has really been a true blessing.
Okay, Margaret, would you like to bring us home?
All right. Hello, everyone. So with the pandemic affecting my job as a preceptor was changed because usually when you start in the ER, you're on your feet running. And when I started first working with Kaylee, we were just getting into the throes of COVID and everyone was afraid to come to the hospital. So the people coming in were very high acuity, but there were less people. And so we had to learn how to do the time management with the high acuity patients. And so it was a challenge to try to teach Kaylee as I was learning myself with COVID patients. So when we were in the COVID area of the ER only doing COVID people, it was like we were both learning and teaching somebody at the same time. But it allowed us to really talk about situations that she had seen, to really debrief on her experiences, like wearing a pepper in a code or a code situation in general, what was expected, what to listen for, what to do. And so it allowed us to do that. As a preceptor, it's teaching and sharing your experiences with them. And so doing it during COVID, it could be limited because you haven't been around COVID. It was new for everybody. Everybody was learning it together. The doctors, the nurses, the respiratory therapists. It was all we're going to do it as a team. And so it included the new grads. Our workplace being affected by the pandemic, a lot of communication, what we don't realize is it can be very nonverbal in our body position and our facial expressions. And so wearing the peppers and the face shields and the gowns, a lot of that nonverbal communication is hindered or taken away. And so you have to change and become more verbal and talk to people even more. And so when you are working with a new person, like a new grad or a new nurse to the unit, you become more verbal and talk more rather than shifting one way or changing your position to say, oh, hey, don't forget about this. It would, you'd have to say that in the room so they would understand and learn. A couple of good opportunities, though, is that when we weren't necessarily in the COVID unit in the ED, we would have our regular patients like heart patients and liver patients and diabetic patients. And so Kaylee was able to get in with those patients and take the time that might not necessarily be there on a normal day to really learn these disease processes and understand, what was going on with this cardiac patient, why we were doing these certain labs. And so with the acuity being high, she got really good exposure to some really sick people that you might not necessarily see every day. So it was a good thing to do. And with those situations, she was able to ask questions at any time, which she did, which is great. And we were able to talk about any situation. If we had a STEMI or a stroke and things moved really fast, we were able to debrief right after the situation to talk about it, to learn about it, rather than her, having to wait for a couple hours because we were moving on to the next thing. So it really helped. I think another thing that affected the job, not necessarily as a nurse or as a preceptor, is that when we first started working together, we as a hospital were still learning what the best treatment for COVID was. And so we were trying to do everything for these patients to make sure, that they were stabilized, that they were going to be safe here, that they were going to be well taken care of. And so we all learned how to care for COVID patients in that one direction. And so trying to teach somebody, this is why we're doing this medication now, this is why we're doing this, for it to be ever flowing and changing as the research came out, could make it a little difficult and affected our jobs a little bit. But overall, teaching Kaylee during the COVID, if you look at it, it could be one of the best ways to do it, because she was able to see high acuity patients in both sides. She was able to help care for COVID patients and is able to do so successfully now. And she's able to successfully care for her other high acuity patients while managing everything. And so it really comes together that even though the orientation process was changed a little bit, it was still thorough enough to give her a good education to where she would feel safe and competent going out on the floor. And JPS did a great job of always supporting us. Our educators were always there, giving us, a good timeline, different resources we could have, informing us of any changes to stay on top of it. And so it really worked out great to be able to do all of that together. I think some of the lessons we may have learned is that, we got to go with the flow, and it may not necessarily be the easiest thing to do, but it is the best thing to do, since it's an ever-changing thing and we're still learning things about it. I'm sorry. But overall, it was a good experience and a good learning opportunity for her to become a great nurse.
Thank you, Margaret. I have found all of your stories to be so impactful, and I want to thank you all for sharing your experiences with us here today. It is time now for our questions and answers for our panelists. Sally, do we have any questions in the queue?
Yes, we do. First, just a comment for Tracy. Thank you for your vulnerability. And then a question probably for both Bianca and Tracy. Can you discuss the third wave that we are seeing right now and compare that to what you guys were seeing at your peak this summer?
Bianca, do you want to answer that first?
Yeah, sorry, I thought I had it unmuted. So the third wave, so just to kind of compare, this last surge that we had in the summer, we had at most, I believe it was about 54 vented patients. Last week we had about 24, and this week we're at 31 vents, and we're anticipating more vented patients. Right now our capacity for the ICU is at about 43. We're at 37, but there are not enough nurses to cover those beds, even if we could fill them. So we're starting to kind of get back towards the times when we were really struggling, for nurses and providers. But I know they've Parkland is very aggressively trying to get travelers to kind of offload some of that, burden, the pressures of the patients, and yeah, that's what I have.
Thank you, Bianca. Tracy, do you have anything to add?
I feel like we're better prepared for it because we've learned so much in the last few months. And we've gotten so many people who have been floated to ICU and have been able to help out, that while we continue to feel very short-staffed, it's not as dramatic as it was in that first time. I think one of the disadvantages is that we haven't really gotten a break, and we're all so tired waiting for this next peak to happen. So we're just kind of waiting and see.
Thank you. Sally, next question.
More questions. What is your advice for new grads or nurse residents entering the workforce? How can we help them adjust?
Kaylee, do you want to answer that first, or maybe Margaret?
It's Kaylee. As a new nurse, for me, I felt like what I always told Margaret was that I was, you know, excited to learn, focus on assessment skills, treat patients, learn time management and stuff like that. And I truly feel like COVID positive patients at this point, I feel like it's now just another kind of patient that I know how to take care of. So it's something where I feel like I already had so much great support from both my preceptor, our charge nurses and managers come around, I'd say at least once a week. They are always coming to me and asking me, what I need and what we can do better and places for improvement. So I felt like my voice was always heard and my input was always very valued there. So I think that personally, I don't have any input to where I could say if I would have had this, I think I would have been better off, because I felt like, if anything, I thought that everybody was rounding on me a ton. So I thought it was really great. But I do think as a new nurse, just having that support and having somebody there, even if you aren't necessarily asking questions, but just having somebody there for support to vent to and talk to, since it is kind of like a really uncertain time and you're not really sure of how you're doing so much and everything is new, just having that supportive person there really made all the difference for me.
Margaret, do you have anything to add?
So if you're starting out as a new nurse, whether it's in the ED or the ICU or on any floors, and you might have to deal with these COVID patients, is I would say always ask questions. If there's anything that you're confused on or concerned about, is just talk to your preceptor about it, or your charge nurses or your team leads. And you can't learn anything if you don't ask questions and get that experience. And that's what Kaylee did, and how she really learned is she was constantly asking questions and understanding why we were doing things and what was the reasoning behind it, to truly understand what those were. And that's what I would say would be the best thing, is to ask those questions, get involved in your patient care, go for it, put yourself out there. The hospitals are providing N95s and masks, and so you're safe and you're protected, and that'll be the best way to learn.
Thank you, Margaret. Sally, do we have any other questions?
Yes. How can we support preceptors when they are burnt out, but we need to fill vacancies?
That's an interesting question. Who would like to answer that? Sally, can you repeat the question one more time?
Sure. How can we support preceptors when they're burnt out, but we need to fill vacancies?
So this is Margaret. I actually am in an office with my educator, Judy, and she was wondering if she could share on this topic a little bit. Is that okay?
I think that's great.
Okay, here's Judy.
Hey, Virginia and everybody. I don't think that question is actually a new question. Maybe I feel that way because of the environment that we work in. But in the ED at JPS, we are constantly having to orient new people. I don't think COVID really put a change on that. It may have added for the preceptors some additional stressors, but that's always been an issue. If you're an ED that takes new grads or takes transitionals and takes experienced ED nurses, I think the big thing is we try to make it a priority that we meet with our preceptors on a weekly basis to kind of see like where they're at and how are they burnt out. Is it that, the past couple times I've had new grads, and new grads are a bigger job than probably your transitional and your experienced nurses, because they do take more. They do take more time. They do take more input. They have come in with a basic foundation, but this is really how they're going to learn to be a nurse. So sometimes it's just as much as sitting down with a preceptor and saying, well, I have some other new staff that are starting. How about this next go around? We don't do a new grad, we do a transitional nurse. So someone who's got their basic foundation already completed, and they just really need to know how to transition into being an ED nurse. I think I have had preceptors come to me that are like, this next round of new people that are coming, I need a break. And I think it's really, really, really important to respect them when they say that. When they say, I need a break, I can take another new person in the group that comes after this one, but this next one that's coming, I need a break, Judy. And so that's what we do. I'll share one. I had a preceptor. She's really good. She's good at no matter what type of level they're at. She's good with experienced nurses. She's good with transitional. She's good with new grads. But she has a special way of her of being able to meet orientees on a certain level. And I had an orientee that was coming through that was going to be kind of a difficult train. She had some special needs that needed to be met in order to be successful in our department. And I really felt like this preceptor was the only one that was going to be able to give that to her. And unfortunately, right when she was starting, that preceptor just asked me for a break. And I was like, dang, so I went and I sat down with her and I talked to her about this new nurse that we had starting. And I said, I really think that the only way that she is going to be successful is that you're going to have to preceptor. I need you. I really do need you for her, and she needs you. And so she said, okay, well, I'll agree to take her and, just give me a break with the round that comes after her. And I said, okay, I really do appreciate it. But I think the biggest thing is just to sit there and stay in close touch with your preceptors, and see where they're at, what their needs are, and accommodate them, because they are a commodity for your department.
Thank you, Judy, so much for that great answer. And Judy is the ED staff educator at John Peter Smith in Fort Worth.
We have one last question, Virginia. For those actively working with COVID cases, what self-care measures are you all doing, trying to find balance with family, job? That's the last one.
Okay, so Tracy, you want to start with that one?
I have been writing silly little things down in my planner. There are some days where when it's my day off, I just go home and I have a hard time getting out of bed because I'm just so drained in every way. And so sometimes I have to write on my list to get out of bed and take a shower. I bought a house, luckily, right before the pandemic started. So I've been really trying hard to actively participate in my life and get my house set up and things like that so that I can do things to be productive. And yoga is life.
Bianca, do you have anything to add?
Yeah, I personally have turned to my faith to kind of get me through the hard times.
Great answer.
Sorry. But
Bianca?
yes, I'm here. So yeah,
Okay.
faith, and I just came back from a vacation, and working out is also a big thing for me. So that's all I got.
Thanks, Bianca. Joelle, do you have anything to add?
I think the only other thing, you really do have to find, time for yourself to be able to be with your family. But then, we also have all the challenges of coming home and stripping down in the garage and heading straight to the shower, and no close contact. That in the beginning was very difficult, especially with children. It's kind of, I guess, been a little bit more lax lately, but since we're going into another surge, you kind of have to look at that too. But staying safe at work, and then that kind of helps you when you get home.
Okay, Sally, I think that was our last question, correct?
I do have one last comment that just came back from Elaine. Just at Children's was on our first panel, they have preceptor-specific RISE sessions to let them unburden. So just a resource at Children's. And that's it. No more questions.
Okay, I would like to thank all of our panelists today. Your stories and your presentations were just wonderful and amazing. I think for the rest of us, we got to see a great picture of what's been happening between schools and hospital partners during this COVID time. And now I'm going to turn it over to Sally for our final slide. Thanks, Sally.
Thank you so much, Virginia. We really appreciate you moderating this session. And again, we would like to thank the panel members as well. Truly some good stories about what our hospitals and schools are doing and how our nurses are making an impact at this time. So thank you to you all. Last slide up here is just for further information. Again, go to our website. You'll find everything there, a link to the CE evaluation. I'm hoping that'll be up today. If not, it should be up tomorrow. You do need to have that completed by November the 13th. It's all online, and then we'll send you your CNE certificate. Then the session recordings and presentations will be posted as well. Those may not be up till Monday. It takes a little bit of time to download the recording for this. So with that, we'll close the session out today and just say thank you to everybody. We're glad you could join us today and participate in presenting and listening to the session. So thanks so much, everybody. Have a good week.
Thanks, Sally. Thanks, everyone.
Thank you, Sally and team, for a great session.
Thanks, everybody.